Let us discuss adenoid cystic carcinoma. Adenoid cystic carcinoma is malignant salivary gland tumor. It is seen in both minor and major salivary glands. It shows perineural invasion and resembles polymorphous low-grade adenocarcinoma. Coming to history of the tumor. In 1856, Phil described this tumor and called it as cylindroma. The term cylindroma was used because probably cribriform appearance is seen under microscope. Also, lots of cylindrical pseudospecies are seen in tumor islands. So, three C's are associated with adenoid cystic carcinoma. One is cylindroma, one is cribriform appearance, and cylindrical pseudospecies. Coming to etiopathogenesis, the intercalated duct reserve cell gives rise to epithelial and myoepithelial cells. Epithelial and myoepithelial cells proliferate to form tumor cells. This is in accordance with unicellular theory of origin of salivary gland tumors. Adenoid cystic carcinoma is seen both in minor and major salivary glands. Among major salivary glands, submandibular glands are mostly affected. Parotid and sublingual glands are not affected as much as submandibular glands. Adenoid cystic carcinoma is mostly seen in 5th and 6th decade of life. Females are more affected than males. Clinically, low-grade and high-grade adenoid cystic carcinomas are seen. Low-grade tumors are slow-growing. They are associated with pain. Sometimes pain is seen even before growth of the swelling. The growth is gradual and constant, and overall it has smooth surface. Whereas high-grade tumors, they are ulcerated, they are painful, and they are abrupt in growth. They cause early perineural invasion and are not capsulated. Overall, there is invasion in perineural areas, they metastasize to other areas, there is high recurrence rate, they are aggressive, and aggression depends on histological grade. So overall, it is considered that grade 1 has good prognosis, whereas grade 3 has worse prognosis. Histopathologically, ductal cells are seen. These ductal cells consist of cuboidal cells. These cuboidal cells have hyperchromatic nucleus. Myoepithelial cells are dark, angulated, spindle-shaped, or sometimes plasmacytoid in shape. They have scanty nucleus. Histopathologically, three patterns are seen: cribriform, tabular, and solid. Cribriform pattern is most common. In cribriform pattern, the islands or basaloid epithelial cells are seen. There are multiple cystic-like species. These are also called as pseudospecies. These cyst-like species are many in number and contain mucoid material. This appearance is also called as sieve-like appearance, and it was also called as Swiss cheese pattern. Individual islands sometimes are covered by prominent hyalinized stroma. Second histological variety of adenoid cystic carcinoma is tabular variety. The tabular variety consists of lots of tubules. The tubules have got a central lumen and are lined by cuboidal cells. Tubules are much in number. These tubules are covered by stromal cells. Stromal cells can be hyalinized or sometimes chondroid or myxoid in shape. We have to remember that the lumen in case of tabular pattern is covered by modified myoepithelial cells and stromal cells. Solid pattern consists of large islands and sheets of tumor cells. The cribriform appearance is not seen. There is increased mitotic activity and focal necrosis. All three patterns can coexist in same tumor, and usually one pattern predominates. Coming to grading of adenoid cystic carcinoma. Now, grade 1 consists of majority of cribriform pattern cells. If the solid pattern is less than 30%, then it is called as grade 2 pattern. But if solid pattern is greater than 30%, then it is called as grade 3. Grade 1 is good prognosis, whereas grade 3 has worse prognosis. Adenoid cystic carcinomas closely resemble polymorphous low-grade adenocarcinoma. Polymorphous low-grade adenocarcinoma doesn't express c-KIT. c-KIT is immunohistochemistry compound. It doesn't have angular cells in enough quantity, and PLGA, although it shows perineural spread, but we can differentiate it microscopically from adenoid cystic carcinoma. Second important differential diagnosis of adenoid cystic carcinoma is basal cell adenoma. In basal cell adenoma, there is no perineural invasion, and basal cell adenomas are common in parotid region. Basal cell adenoma is a benign tumor. Third important differential diagnosis of adenoid cystic carcinoma is basal cell adenocarcinoma. Basal cell adenocarcinoma, as the name indicates, is malignant. But in basal cell adenocarcinoma, histopathologically, peripheral palisaded nuclei are seen, and there is no cribriform pattern seen in this tumor. Coming to treatment of adenoid cystic carcinoma, as there are chances of recurrence and it is an aggressive tumor, so radical surgical resection is done, followed by radiotherapy. The prognosis is not good, and 5-year survival rate is 75%, whereas 15-year survival rate is 10%. So, thanks a lot